Dear students and colleagues, today we will discuss about H. pylori infection because it's a very common and there are mistakes in diagnostic and treatment. There are new consensus about diagnostic and treatment H. pylori infection. It's a Maastricht 6 consensus which we follow and use this recommendation. Generally, H. pylori is a flagellated gram-negative bacillus with infection rate up to 90% in some populations and countries. And it's well known that this bacteria colonize human stomach. And there are large variation for this bacteria across the globe. And necessary to know that spread of H. pylori can occur directly from one person to another or indirectly from a person to the environment. H. pylori DNA detected not just in stomach but in human feces, saliva, supragingival plaque, and it suggests a fecal oral and oral route of transmission this bacteria. High pressure profession, water supply, smoking, dietary habits have been associated with a high risk of H. pylori infection occlusion. It also been suggested that gut microbiota may contribute to interfamilial transmission of H. pylori infection. It means that better to recommend to test all members of one family for H. pylori bacteria if there is this H. pylori in one of the family person. It's well known that H. pylori infection is associated with the gastrointestinal diseases and first of all gastritis, peptic ulcer disease, gastric mucosa associated lymphoid tissue lymphoma and gastric cancer. And it's well known that there is a cascade of chorea with the progression of normal gastric mucosa to superficial gastritis, gastritis with atrophy, intestinal metaplasia and atypical hyperplasia of mucus, and up to gastric cancer. That's why the role of this bacteria in mechanism of gastric cancer is very important, and it means that necessary to test and treat patient with H. pylori infection. A high cytoxin associated antigen A, CAG-A positively in H. pylori strains is associated with more severe gastritis according to some histological features of disease and more high rate for gastric cancer. H. pylori genotypes, they differ among population in different regions and groups of patients. And for example, in a patient with chronic gastritis in Mexico, greater prevalence of VAC-A, CAG-A plus and BEP-A2 minus genotypes. Pathogenesis of H. pylori infection, first of all, connect with such enzymes of bacteria as urease, which neutralize stomach acid, with adhesins, which has adherences to host cell and mucins, and with a flagella, which possible to motility, chemotaxis, and biofilm formation. It means that these substances, they are pathogenic, plus virulent factors such as CAG-A and VAC-A, which can induce pro-inflammatory response and promotes double-strand breaks. It's necessary to note that H. pylori can cause not just gastritis and stomach diseases, but it can lead to H. pylori associated diseases as neurological disease like Alzheimer's disease, Parkinson's disease, to hematological disorders like iron deficiency anemia, B12 deficiency anemia, can be associated with a dermatological manifestation like chronic urticaria, rosacea, and with the diseases of hepatobiliary system as non-alcoholic fatty liver disease, hepatic heart carcinoma, cholangiocarcinoma. It means that H. pylori infection has not just local but systemic effect, and sometimes in patient who has a skin diseases or neurological disorders or liver disease, we should check and test for H. pylori infection, and in case of positively, it's necessary to recommend eradication treatment. About diagnostic methods and strategy for patient with H. pylori infection, we have a non-invasive examination test as a urea breath test, which easy to operate, low technical requirements for this test, and high compliance with the patient. But this test has a disadvantages as some drugs as a proton pump inhibitor, H2 histamine receptor blocker, some food can change result of examination and can be false positive result for urea breath test in patient. That's why not too high sensitivity for this test, but it's invasive and non-invasive, and it's very easy to use after eradication treatment and control for effectiveness of treatment. The second non-invasive test is a stool antigen test. When we control presence of antigen of H. pylori infection, it's enough informative, easy operate, and very good compliance with the patient. But there are such disadvantages as storage, transport, fecal samples may influence the result, but anyway, it's enough informative and easy to do this test. Non-invasive examination, it's of course serological, but with serological examination we control level of immunoglobulin, it means antibodies. Advantage is that no effect on gastric bleeding, proton pump inhibitor, taking bismuth, antibiotics, but disadvantages, a positive serum test cannot serve as a basis for ongoing infection. It's maybe patient had before infection, recover, but this serological test can stay positive. Among invasive examination, we can talk about endoscopic examination when we take a biopsy from stomach, and it's enough informative methods, but accuracy and specificity of result vary considerably. Histological examination has a high sensitivity, specificity, but disadvantages, the ability to observe have a significant impact on the analysis of results. Culture test has extremely high specificity. Culture times are longer, and the quality of culture condition affects the result. It's a disadvantage of these methods of examination. We can recommend, or we can use rapid urease test. It's a quick, easy, accurate, but bacterial density and morphology in biopsy might affect the results. And one more is a PCR polymerase chain reaction. It's an automated, simple, accurate, rapid, efficient test for diagnosing H. pylori infection. But contaminated samples or samples containing PCR blockers affect the accuracy of the result. It's one of the disadvantages of this PCR test. About principle of treatment patient with H. pylori infection. There is one principle that patient should be test and treat. If we have a positive result in one of the methods you use for patient, it means an indication for eradication. For eradication scheme, we can use standard triple therapy for first-line treatment. It's a very common methods of eradication and consists of proton pump inhibitor as omeprazole, lansoprazole, pantoprazole, rabeprazole, and esomeprazole, and 2 antibiotics. From antibiotic, we very common use amoxicillin, clarithromycin, levofloxacin, metronidazole, and others. But necessary remember that we use standard scheme of treatment empirically, and we should take into account that the sensitivity and level of resistance to clarithromycin in different regions can be different, and we should use such information for initial treatment of patient. Typically, the regime of standard triple therapy should be continued for 10-15 days until H. pylori is completely eradicated. Before the duration of treatment was 7 days, but now we have a new recommendation that minimum treatment should be 10 days because it increases positive result of treatment. At present moment, we have a new treatment, new drug as a vonoprazan. It's a novel potassium competitive blocker which has an effect for acid suppression. But now we need further studies on effectiveness of treatment with vonoprazan in a scheme of combination treatment patient with H. pylori infection. We have another opportunity and scheme with the treatment by bismuth quadruple therapy, which consists of a proton pump inhibitor, bismuth salts, and 2 antibiotics. Bismuth has a mucosal protective effect and has a bactericidal effect on H. pylori by inhibiting some of enzymes as urease, fumarase, alcohol dehydrogenase, phospholipase. And this scheme of treatment is especially choice for patient who has a peptic ulcer disease, erosions or ulcers in stomach, in duodenum. We prefer this scheme for initial treatment of patient. For second line anti-H. pylori infection treatment, we have a new recommendation of Maastricht 6 consensus, and you see at this slide regimes we can use for patient and duration of treatment. Again, it's a minimum 10 days and up to 14 days of treatment. And from drug, you see at this table, we can use standard bismuth quadruple therapy, which includes standard dose proton pump inhibitor bis daily, plus bismuth 300 mg 4 times daily, tetracycline 500 mg 4 times daily, and metronidazole 500 mg 3 times daily. Another scheme can include quinolone, fluoroquinolone amoxicillin triple therapy, which includes proton pump inhibitor in standard dose bis daily, levofloxacin 500 mg 4 times daily, amoxicillin 1 gram 2 times daily, and during 14 days. The third scheme can include fluoroquinolone amoxicillin quadruple therapy, which consists of proton pump inhibitor in standard dose bis daily, bismuth 300 mg 4 times daily, levofloxacin 500 mg 4 times daily, amoxicillin 500 mg 4 times daily during 14 days. Next is levofloxacin tetracycline quadruple therapy, consists of standard dose proton pump inhibitor bis daily, bismuth 300 mg 4 times daily, levofloxacin 500 mg 4 times daily, tetracycline 500 mg 4 times daily, minimum 10 days up to 14 days treatment. And high dose dual therapy with a standard dose proton pump inhibitor 4 times a day. You see, it means high dose of proton pump inhibitor, and amoxicillin 750 mg again 4 times daily. This scheme during 14 days has a good effect and high level of positive result after eradication. But again, it's all second line treatment for patient. We use when patient has failed first line treatment, again positive result for H. pylori infection after first line treatment, or if patient is in country with a high level of resistance to clarithromycin. If we have an algorithm of second line treatment of H. pylori infection, here you can see that the solid lines denote second line therapy with a per protocol eradication rate exceeding 85% in most countries, and dashed line denotes second line therapy with per protocol eradication rate exceeding 85% in some geographic areas. And you can see this combination bismuth quadruple therapy with amoxicillin levofloxacin quadruple therapy or high dose dual therapy. It's which with the dash lines just in some geographic areas is effective more than 85%. If summarize all this data, we can see that H. pylori infection treatment with the rising prevalence of resistance to levofloxacin, the eradication rate of levofloxacin amoxicillin triple therapy is suboptimal in the second line treatment H. pylori infection at present moment. And currently for second line treatment of H. pylori infection, we recommend or standard bismuth containing quadruple therapy, or tetracycline levofloxacin quadruple therapy, or levofloxacin base sequential quadruple therapy, or amoxicillin levofloxacin quadruple therapy, or high dose dual therapy. Plus H. pylori infection treatment can include adjuvant therapy as probiotics, which secreting antimicrobial compounds, competent for binding sites, improve the mucosal barrier. We can use nanotechnology, which promotes the target delivery of oral drugs. We can use traditional Chinese medicine, which has the antimicrobial, anti-inflammatory properties. That's why our possibility for treatment H. pylori infection much more than 10 years ago, and of course we use it, and necessary, I remember one more to tell about it, that necessary to test patient in period of time 4-6 weeks after eradication for H. pylori infection. And for final test, we can use all tests instead of serological, because antibody present in serum much more time than antigen of bacteria. Thank you very much.